Hey everybody, welcome back to Pharmland. I am Bradley Nelson and my co-host Tom Davies are here to dish up the freshest pharmacy information and insights to benefit advisors, employers, and anyone else looking for a better understanding of the industry. As you know, we try to take the biggest topics and dig deep, offering perspectives that you won't find anywhere else. And just to let you know, Pharmland is brought to you by Farm to Table, an educational program from RxBenefits. Today, we're going to be talking about biosimilars. Are they really that similar? And we are joined today, again, Tom Davies, my co-host, as well as a wonderful guest panelist today, Ruth Opdycke. Ruth, how are you doing today?
I'm doing wonderful, Bradley. Thanks for the invitation to join you in town today. I really appreciate it, and particularly the opportunity to talk about biosimilars.
Excellent. Ruth, can you tell the audience a little bit about yourself? They know too much about me and Tom already. So give a little bio about yourself.
Thank you, Bradley.
So I'm a pharmacist by training. I've been in the pharmacy benefits space now for 30 years. I want to age myself there. Been working with a variety of different clients to help them better understand the pharmacy benefits and where are the optimal opportunities to improve the cost efficiency of the program, like maintaining the clinical robustness of the program as well. So I love the pharmacy space. It's always been one of my dreams to be a pharmacist, and I've been truly blessed to be able to practice in this field for as long as I have.
Well, Ruth, thanks again for joining us. We're really looking forward to this conversation. Just to kind of level set, Bradley, this is podcast number 5.
Podcast number 5. We haven't been canceled.
How time flies, for sure, right? And we spent the first 3 podcasts or so talking about GLP-1s and the market event around GLP-1s. Then we transitioned to prior authorizations and the impact of prior authorizations, the importance of prior authorizations. And I think this transition to biosimilar fits really nicely, right? Not only is it a market event, maybe not to the degree of GLP-1s, but certainly up there. And then the utilization of biosimilars may be impacted, right, positively and potentially negatively by the prior authorization process. So I think this is a really great topic to be included as our podcast number 5. So I think we just need to kind of level set. And I'll just throw this out there. What is a biosimilar? Is it the same as the generic medication?
Not necessarily. It's really not by definition. When you think about a biosimilar, you have to think about what's the entity, the active entity, and how is that created. And biosimilar are actually biologic drugs. And the biologic drug is an entity that is created by living organisms. So cells create these drug-like products. And those products have active actions within our body to help treat disease. But it's a very complex process because it's created by a living organism. The entity itself is a very large molecule, and it can have all these different folds and different extra elements within it that makes the manufacturing process for that biologic product very, very difficult to duplicate. So granted, the generic drugs are products that are produced more in a chemical synthesis method as opposed to being produced by a living organism. So that manufacturing process for generic drugs is much more defined. They don't need to produce studies that show equivalency in therapeutic effect because it's a chemical equivalent agent. A biosimilar manufacturer, on the other hand, needs to do those things plus the additional step of performing clinical studies to demonstrate efficacy of that product compared to the reference or branded biologic drug.
Are more generic manufacturers now entering into the biosimilar space to try to gain market share? Is that what's going on these days?
So what we're seeing is not necessarily the traditional generic manufacturers entering the biosimilar space. We're seeing new companies being formed that have the greater expertise and knowledge in-house how to manufacture these biologic products, because it takes a whole different skill set to really understand how to produce a biologic product from living organisms. Think about it, somebody who makes a bread from a box or cake from a cake box mixture versus someone who creates a cake from scratch where they understand, particularly a yeasted type cake, they understand the way a yeast will form and will create the necessary air pockets to make a nice fluffy cake. It's completely different in terms of baking processes. And the same is true for synthetically producing a generic drug and biologically producing or growing a biosimilar product.
Appreciate that insight, Ruth. The only thing that I would add to that is the process of the work associated with development of a biosimilar product, because there's some variance in the molecule and some additional testing that is necessary. On average, it costs about $200 million to bring one of these agents to market, and it takes approximately 8 years. So there's a
Right.
lot of investment that is currently being done with regards to biosimilars, with the understanding that there's likely a lot of money to be made out there as well. If there is a market share shift from the originator product or innovator product to your biosimilar. So there's a lot of opportunity and focus associated with biosimilar availability. And I'm really hopeful, based on what we've seen recently, that this is a trend that will ultimately continue.
Absolutely. And well, and if you look at the pipeline where manufacturers are looking to develop new drugs, the majority of the work is in that biologic space, which means we will have the greater number of opportunities for biosimilars to be produced as those biologic products come off patent. The biologic product typically has 20 years of patent protection from the day that it's submitted or filed with the patent office. It's a much shorter patent protection for traditional drugs, non-biologic drugs.
So we have quite a few entrants within the marketplace today. Adalimumab, or the biosimilar for Humira, is getting a lot of attention. But any thoughts or any insight as to, the total number of entrants that are in the marketplace today? What are the different conditions that they treat?
So as I think it was around April of 2024, the FDA had approved 50 different biosimilar products. And of those 50 products, they were referenced to 15 different branded biologic products. Cancer treatment or supportive therapies, the anti-inflammatory conditions. So you think of things such as rheumatoid arthritis, psoriasis, psoriatic arthritis, GI conditions such as Crohn's disease. Now have biosimilar insulin products out there too. So that's the spectrum. And if I, as an employer, look at my pharmacy drug spend and go to the specialty section of the pharmacy drug spend, all those therapeutic conditions that I just mentioned are more than likely going to be within their top 5 therapeutic areas for specialty drug spend. So employers are really looking forward to the potential savings opportunities associated with biosimilar drugs as more hit the market.
And just to add one thing to what Ruth is mentioning, I believe, if I remember correctly, in 2023, or actually 2022 into 2023, Humira, the number one selling drug at the time, was actually drawing in revenues for AbbVie north of $20 billion. So as Ruth and Tom both mentioned, just having competition in that space is going to make somebody money, even though there's a large upfront investment. Just depends on market share and how you gain market share as a biosimilar company. So I want to ask this question: how do these biosimilar manufacturers, how do they gain market share from basically the 800-pound gorilla that was Humira?
I think one of the mechanisms with regards to biosimilars, the potential for differentiation within the class, is the designation of interchangeability. And one of the ways to potentially, right, for a biosimilar manufacturer to garner more market share sooner than products that don't have interchangeability status. So Ruth, what is the process behind interchangeability status, and why is it important?
So when the FDA established the pathway for biosimilar approvals, they did one additional piece, which is much different from what we see on the traditional generic side of the approval pathway. They created what you call the interchangeable designation. And it's interesting, only the United States FDA created this interchangeable designation. The European Medicines Association also has a biosimilar approval pathway, but they then create an interchangeable designation. Everything is equivalent. So the FDA said, okay, if you want to create a biosimilar and you want to have the ability for a dispensing pharmacist to dispense a biosimilar to the reference drug without having the prescriber write a brand new prescription, then you need to get the designation of interchangeability. And so they have to run studies that demonstrate if the individual who's taking the biosimilar product switches to and from the reference originator and back and forth, but there'll be no change in their effect from an efficacy perspective, and really no change significantly in any other effects, such as adverse effects and things like that. So that's a whole another set of additional studies and extends the time frame and the
And the
financial
cost.
commitment, the gap cost that the manufacturers have to commit to get their biosimilar approved.
So this interchangeability status, right? So one of the key differentiators at the point of sale, there's the potential for a pharmacist, right, to make that change, with the caveat being it's subject to state law. So if you look at the resources that are currently available out there, so I just grabbed a couple of states, right? I looked at Alabama, and there is the potential for a pharmacist to transition to a biosimilar with interchangeable status at the point of sale, as long as it's not a Medicaid patient. So that's one caveat. Other
Yeah.
caveats that I've seen is there has to be, if the conversion is made, it has to lead to a lower cost for the member. So if we think about what's going on today within the marketplace, right? And we think about Humira and the copay assistance that's available. There's scenarios where the copay assistance will cover all but $5 for the member on Humira. So unless the biosimilar has a more robust copay assistance program that potentially covers, only means the patient has to pay $4.99. There is the potential that they can't make that change. So there is some nuance to the interchangeability status based at the state level.
Many of the states also require that even if the dispensing pharmacist makes that interchangeable switch, they still have to notify the patient and the prescriber of the switch after the fact. So they don't have to get approval up front necessarily, right? But they have to send notification. So what's interesting is when you compare and contrast the biosimilar space to traditional brand generic drugs, there was no additional interchangeability requirement for, for pharmacists to dispense generic atorvastatin over brand Lipitor. The vendor has to be notified by labeling. The manufacturer has to be on the prescription bottle label, but doesn't have to be a verbal approval with the patient or with the prescriber. And so there was great flexibility for dispensing pharmacists to be able to dispense generic drugs when the product became approved generically.
Right. And we've seen some legislation recently, early as as recent as 2023, it's currently labeled as the Biosimilar Red Tape Reduction Act. And the real purpose behind this particular piece of legislation is to essentially really mirror what's going on in Europe. When a biosimilar is approved, it doesn't require switching studies It doesn't require an interchangeable designation, but the hope, if this does get enacted, it'll increase access.
I want to ask both of y'all, why is the red tape there for biosimilars versus generics? Because that's a big differentiator that drives up cost for biosimilars. So, what do you think is the rationale behind that additional red tape?
There are all sorts of barriers that are put into place to try to retain market share for branded products. The pharmaceutical industry has a very strong lobbying effort. And from my opinion, when the FDA was drafting the guidelines around biosimilar approval pathway, there was probably a very loud voice in the corner talking about, oh, but these are biologic products. We can't be guaranteed that they'll be just as effective, that they'll cause adverse effects or immunogenic responses that we don't see in the referenced product. And so we feel that if there's any interchangeability here, you really need to have an additional level of proof with these additional clinical studies.
What is the adoption of biosimilars just in general today? And why have they not really caught on like we think they should, particularly in light of market events that have gone on?
Yeah. So right now, US biosimilars have increased to just about 9.4 billion in 2022. And that's gone up from 24 billion since a total of 24 billion since the first entry in 2015. And the adalimumab or Humira biosimilars have obtained 2% market share at the 1-year market, right? So but the Humira biosimilars came out in 2023, and there's 10 different biosimilar products on the marketplace. And when pathways were first approved, the industry looked at the experience in Europe, which doesn't have the interchangeability requirement, recall, and has much more control over the prescribing community because of the way the health system is set up. And they saw very good adoption of biosimilar products. I think people had a certain expectation that we would see the current level of generic dispensing rate hit the field running with biosimilars, that we would see 90% of biosimilar opportunities dispensed biosimilarly. And that we have a much more complicated process for dispensing and prescribing these products because they are biologic. And you have this barrier with interchangeability. So we're actually, in my opinion, we're actually seeing pretty good adoption. And there have been a few recent market events that are definitely going to uptick and increase the biosimilar dispensing rate.
Aren't the headwinds the same though? If you think about the years, aren't there similar headwinds though?
I think there's similar headwinds. I think there's a level of impatience with the biosimilars because when we talk to not only patients that are on these drugs, right, and the affordability associated with these medications, but it's all over the news with regards to the pharmacy benefit and the impact of these drugs. 2% of the population, right, driving 50 to 60% of the overall pharmacy spend. So I think that there was a lot of promise and hope associated with biosimilars, that they would be available. We'd have rapid adoption, which ultimately drive down costs and ensure that we're able to preserve these benefits for employees, right, and clients. And there's some impatience within the marketplace with regards to biosimilars, but I do feel there's momentum, right? I've spoken with colleagues here not too long ago where they said biosimilars will never crack up what we want it ultimately to be, right? We had experience with biosimilars and adoption, but a lot of the biosimilars were initially approved were on the medical side, right? And so it was really tough for us to gauge what it would look like on the pharmacy side of things. And I'm hopeful, if I want to term biosimilar one word, I'm hopeful, right, that we're ultimately going to see, what we want to see with the impact of biosimilars. It just takes time. There was a recent study published by a biopharmaceutical manufacturer that looked at the time it takes for biosimilars to achieve greater than 50% of the market share. And on average, it takes about 3 years. But what's interesting about that, if you look at that aggregate, so biosimilars for cancer treatment, biosimilars for inflammatory conditions, biosimilars for the treatment of diabetes. In aggregate, it takes about 3 years for you see a market share shift of 50%. With the caveat being, if we look at the adoption of the biosimilars for supportive care in cancer or the treatment of cancer, we're much higher than that 50%. We're close to 85% adoption. But then we shift gears and look at the inflammatory conditions, we're closer to about 27% adoption. And that includes infliximab, which came to market in 2017 or so.
2018. Yeah.
2018. So it's really interesting if you start to parse that out. There's a lot of uptake, market share shift based on the category. And I'm hopeful that we're going to see similar or quicker market share shift with the Humira biosimilars and the headwinds that you and Bradley alluded to there. What changes within the marketplace have driven, right? There was, as we stated, there was about 8 entrants in 2023, 5 to 8 entrants for adalimumab in 2023 that were competing for 2% of the Humira market share, right? So what has changed?
So we're seeing right on the cusp of some really huge market changes that by the end of this year, we're going to see a huge uptick in dispensing Humira biosimilars. One is the first approval of an interchangeable adalimumab biosimilar, which is both citrate-free and high concentration. And that citrate-free high concentration adalimumab represents, I think it's about 80 to 85% of the market share of all the Humira prescriptions that are dispensed in the United States. The other huge thing that has happened is CVS Caremark has come out and made very firm formulary decisions that were effective April 1st of this year. And they're sticking with those 3 biosimilars to Humira. Humira is off the formulary. The other thing that has happened separately is CVS Caremark, the Care Corporation, has established a pharmaceutical company, manufacturing company called Cordavis. And Cordavis has inked an agreement with AbbVie, the manufacturer of Humira, to produce a private label version of Humira's high concentration citrate-free product that CVS Caremark will source and dispense from their specialty pharmacies. So CVS has actually gave notice out 60 days in advance of this change and already started reaching out to prescribers and to patients that they needed to transition from Humira to one of the biosimilars.
So CVS is one of the big 3. Bradley, do you think the others will follow suit?
Well, we know, just have a recent announcement by Evernorth, right? Where they are now going to quote co-prefer and have a very similar option that CVS has with a company they own called Quail or Qualit. Pronunciation, don't hold me to that, Evernorth, if you're listening to this podcast. But they have a subsidiary that is very similar to the Cordavis product, but they have inked marketing agreements with Boehringer Ingelheim for the Celtizo high WAC, low WAC interchangeable. The only difference between CVS and Evernorth's announcement is that CVS made the conscious decision to make a blanket Humira exclusion on their formularies, whereas Express Scripts is going to co-prefer. So the adoption curve for an Evernorth client is going to probably look a little bit different than an adoption curve for a CVS Caremark client, because you have that member choice aspect of it. Members may not want to move. Doctors may not want to move. People don't typically like to change if they're not forced to have a change. So there may be some potential adoption curve issues, at least with Evernorth, into the biosimilar realm. But I see that if I were Evernorth, this is a test case to see if I want to have a full-blown exclusion later on. Can't speak for them. Don't know what's happening in their discussion, halls of discussion, but they've taken a interim step, I would say, not the full step that CVS Caremark took. And I can only bet that Optum RX from United Healthcare is looking at what am I going to do for January of 2025. I'm sure that's probably part of their discussion these days.
So anytime one of these things happen, right, it's a push and pull, right? So we're opening up access. If I'm a pharmaceutical manufacturer, right? If I'm AbbVie, if I'm J&J with the potential or the recent approval of Stelara biosimilars within the marketplace, what are some strategies that the pharmaceutical manufacturers potentially could deploy, right, to ensure that they continue with similar revenue streams?
Well, it's interesting because anybody turns the TV on, they're going to hear or watch a streaming, right? Line with this is that commercial free. The majority of the commercials that they're going to hear are related to drugs. And the majority of those drug commercials are going to be biologic drug commercials for products that have the same therapeutic indications as the products that have biosimilar competition now. So AbbVie, Rinvoq, one of their products, it has almost mirrored indications to Humira. And you see Rinvoq commercials on the TV all the time. Skyrizi, another AbbVie product, you see Skyrizi commercials all the time. Smaller set of labeled indications in terms of the conditions that they treat, but it will replace a portion of the utilization that you see under Humira. So that's one of the avenues that the manufacturers do, is looking for the next best product. And each iteration brings a new opportunity for individuals maybe who weren't responding to the current product, right, to have an alternative therapy that's available. But it also creates that ongoing pipeline for revenue stream, which is the business of the pharmaceutical manufacturer, right? To stay in business, they need to make sure they have a pipeline of new therapies.
And they can always purchase a pipeline, right, Ruth?
Yes, absolutely.
So I think we've done a nice job of, hopefully, for the audience, laying out the foundational aspects of biosimilars, where we feel, in our opinions, where we feel biosimilars would go in the coming years, right? There's a pipeline of biosimilar products currently being studied. There's 50 agents available here in the US as of, I think, February of this year. April of this year. Not only the Humira, but there's a Stelara. There's two Stelara biosimilars. There's an Actemra biosimilar. All fall into that inflammatory condition category. We've taken the view of formulary management, what has been done historically, but one of the keys to adoption of biosimilars is provider being comfortable with the utilization of biosimilars. And if I think back to my health plan days, we were very early to adopt the biosimilar for infliximab. The problem was we didn't truly appreciate the impact to the provider, and our initial go at this formulary change was a mandated switch. Providers are not too comfortable with mandated switches. And so we learned a lot while at the health plan on how to navigate those waters. And one of the, if you look at some of the provider consensus report, McKesson put together a nice study on evaluating rheumatologists, gastroenterologists, utilizing biosimilars and their level of comfort with biosimilars. And one of the themes that was echoed through that study was, first of all, mandated change is not something they're comfortable with. In addition to that, the question around non-medical switching is another one that gives providers some level of hesitancy. They're comfortable starting a patient generally on a biosimilar, but it is the patients that are currently stable and doing well on the innovator product, when is it best, or is it best to transition them to a biosimilar? So as we look to the world of biosimilars in the coming years and this real opportunity for overall cost savings, Ruth mentioned what, $24 million in savings associated with biosimilars since 2015. If we look at the same time frame in Europe, they're closer to $70 billion in savings, with the caveat being their cost of Humira in Europe is about 10% of what we're paying here. So even with that smaller delta, they've seen significant savings. So there's real opportunity here, but we've got to make sure that we're having those shared conversations with the provider community to really avoid the mandated change, right? And having more of a collaborative conversation and allowing for, in certain circumstances, the continuation of an innovative product until we have additional data that may support, right, the value of non-medical switches, more robust data, I guess you could say. So I think that's one of the hurdles. Any other hurdles you two feel with regards to biosimilar adoption within the marketplace in the coming years?
I think that elephant in the room we haven't really talked about is on the financial side, the impact to a client's rebate stream with biosimilars. Tom, you mentioned low WAC, high WAC differential, the price of biosimilars when they're launched. And the biosimilar manufacturers have recognized that they need to compete with the net cost of the reference products. And that net cost is the cost of the product less the rebates. At whatever point those rebates are paid, right? That's your net cost of the product. Biosimilar manufacturers can't necessarily compete out the gate at the same net cost level as a branded or biologic manufacturer because they've had all the recent costs of product development. For usually smaller startups, they just don't have all the other drugs marketed to support them in that. And so one thing that they have done is they've learned through the initial launch that they can't come out just a little bit below the biologic price. They have to come out deeper, much deeper, and they can't compete on rebates. And so if a biologic product on the formularies move to a biosimilar product, the rebates won't be the same size as you see with the reference product. And so downstream, a client will not necessarily realize the same rebate revenue associated with these biosimilar products, but what they will realize is lower costs up front, so better cash flow up front because they're not paying the higher inflated prices of the originator at the point of sale. So it really boils down to an employer making the decision of, am I going to be chasing rebates on the back end, or am I going to really try to work with my pharmacy benefit manager and encourage and support utilization biosimilars out the front gate and improve that cash flow? And then give that same message to my members in my benefit plan that biosimilars are one of the mechanisms that we're taking to help maintain the resources that we need to be able to continue to provide you a full benefit.
Just one other thing to add to Ruth's commentary, because I think that is an extremely important piece of advice that all benefit consultants should adhere to. In our current economy, with interest rates going up, and it's a lot harder for people to borrow money, and cash flow becomes even more important. Benefits are a business. Health plans are a business. You have to run it tight ship when there's a credit crunch. In some cases, cash flow becomes a more important factor than chasing a rebate. And Tom, just to piggyback on something you mentioned a few minutes ago, also understanding if a biosimilar manufacturer can actually provide an incentive for a member to switch, such as a low or no copay or copay assistance model, that goes a long way because innovator companies have a lot more levers to throw in order to create market share opportunities or retain market share opportunities for them. So making sure that a member isn't adversely impacted is going to be a big deal. And then lastly, the federal government. Medicaid is the biggest recipient of rebates out there in the marketplace. The federal government does have a role in propping up why innovator products are still used, even certain brand products in the brand generic dynamic. So it's very important to understand that even a government-sponsored plan can influence what happens in the commercial markets. So hopefully this gives a little bit of a broader discussion and can potentially lead to even more discussions through our Pharmland podcast. So we're going to wrap it up for this episode. I want to, first of all, thank Ruth Opdycke for being part of our discussion today. Ruth, it was a wonderful discussion on biosimilars, very educational. So thank you very much for being here as part of this Pharmland podcast. And Tom, it's good to see you as always, my friend.
A lot of fun. Appreciate it. And I don't feel that the biosimilars is going to be a one and done topic.
Possibly not. We'll be revisiting it. But until the next time, I'm Bradley Nelson. This is Tom Davies. And for our guest, Ruth Opdycke, thank you for listening to Pharmland.